Patient safety. So this is something we've touched on, we've been touching on since the beginning. Our patients, their safety is paramount when they're under our care. Should anything go wrong, and it was due to our negligence or even, I don't want to say lack of knowledge, but yeah, we're responsible. And so the excuse of, well, I didn't know doesn't fly very often when it's your responsibility to understand the instrumentation of the equipment that we're using, the potential side effects and adverse effects of the materials we're placing on the patient, or at the very least, where to look if something were to happen, and how to follow up if something were to happen. So it's all of our responsibilities to make sure that our patients are safe whenever they're under our care for the entirety of their time with us, even when we're not actually running the study, before, after, whatever. And that includes too if they have patient family members coming with them, things like that. So the things we're going to cover today are fall precautions, electrical safety, chemical safety, and then disaster plans. And then just we'll finish up with some ethical, legal issues. I know fall precautions, we've covered it. There's another little video up on Blackboard that Sydney did that kind of covers fall precautions. I don't know if you guys checked out some of the new videos that were just posted. But it's our responsibility to use our due diligence and our common sense to figure out who's at risk, and what we need to do to make sure that they don't fall. Because the name of the game here is just prevention. Prevention is key. So we need to identify who's at risk. If somebody has a history of falls, so that's in that questionnaire where it says, have you fallen within the last 90 days? If the person checks yes to that, regardless of the reason why they fell, they're a fall risk. Even if it was like some fluke thing, it was really bad weather or whatever, ice, they're a fall risk. If they use any type of walking assistance device, a walker, a cane, a wheelchair, anything like that, the older they are, anybody that has difficulty walking. And then there's this huge kind of subsect population that, and there's so many different things that I'm not going to list every single thing that could make a person at risk for falling. This is where you've got to use your critical thinking and common sense to figure out where we go from here and who's at risk. What medications are they taking? What medication combinations are they taking? Are they combining a sedative with an anxiolytic, something that's going to treat their anxiety, that's a depressant, and something else? Like, are they combining with alcohol? Like, that's amplifying their risk of falling. Do they have a chronic pain disorder, fibromyalgia, blah, blah, blah? That alone can make a person fall risk, but then what medications are they using to treat it, right? Usually like heavy duty pain meds. Somebody taking an aspirin or a Tylenol doesn't mean that they're going to be at a fall risk, but somebody taking hydrocodone, I don't even know the names of, like, off the top of my head, I can't even think of the other names of like these heavy duty pain meds. Tylenol 3, that's Tylenol with codeine. So you really have to use just your common sense. Keep the walkways clear. That's seemed like, of course, Mandy, why wouldn't I do that? But when you start getting out there, where are you leaving your cart with all your equipment? Where are you leaving, your stuff? When you come in the lab, where are you dropping your book bag and your stuff? You're not really giving it much thought to, like, let me make sure this is out of the way. Let me make sure nobody's going to be able to walk or trip over this. We generally tend to turn the lights down in the sleep labs at night, so that no light filters through their door, under, like, around the cracks of the doorway and stuff. And anybody that has to go to the bathroom, they're not hit with these really bright fluorescents. So it's easy to, like, let it get too dark though. You have to make sure that there's a small safety lights kind of posted along the hallway. I know you're thinking, like, well, shouldn't this already be set up? Why is it my responsibility? It is your responsibility. We don't know how it was left the last time. The light bulb might have gone out. It's these little minor things that, I can't necessarily train you for, but you just have to use your common sense and be proactive about these types of situations. When appropriate, you're going to use bed rails to help a patient from falling out of bed. Now, bed rails do not mean, like when I say fall precautions, I don't mean you're just going to automatically, just because a person has a risk of falling on the floor doesn't mean they're a risk of falling out of bed. So bed rails is not necessarily something that we add with every single patient. Bed rails are more for pediatrics, REM behavior disorder, and nocturnal seizures. That's when bed rails always have to be used. And there are a small subsect, though, of patients that are at risk for falling out of bed. And it's almost one of those things that you kind of have to deal with it as they come. Like, I've had patients that were so not mobile or ambulatory that just getting them into the bed was difficult, and they could not position themselves away from the edge. And it was hard. And like, even somebody that wasn't necessarily a fall risk, just for whatever reason, either the height of the bed or whatever, their knees, something, they just couldn't get into bed at a safe distance away from the edge. And in those instances, I would put up bed rails. But it was one of those things that at the time, I used my common sense to add them after the fact. Not like, oh, this person had knee surgery 2 years ago, I'm going to add bed rails. As an adult, how would you feel getting into a bed, normal, healthy adult? And it's like, well, you fell over winter because of the ice, so I'm going to put up bed rails because you're clearly a child, right? Like, use common sense. Anybody that's at risk for falling, ask for another help, ask for help when necessary. You're not going to be, you don't want to try to catch the patient. You're not going to be able to. Your instinct is going to be to try to, but that's where these lifelong injuries can occur. You hear this from healthcare workers that have, just twisted wrong, lifted wrong, and then the rest of their life they're dealing with this ongoing back pain issue. So ask for help, anticipate needing it, especially, for somebody, even like the littlest person. I'll never forget, this patient needed help getting up from the chair, and it was this little old lady. I really didn't expect like to get really yanked. And then so I give her my hands and thinking like she's just going to use me for a little bit of assistance. I literally had to like pull all of her weight up, and I was not prepared for that. Like, I almost toppled back over on top of her. So just kind of trying to prepare for those situations, because it's all about prevention. The amount of paperwork, the logistics, and the liability of allowing a patient to fall under your care when you didn't do everything in your power to prevent it, it's just a nightmare. It's an absolute nightmare. Jobs have been lost because of that. So whatever you can to prevent it. Every single thing that we use in the sleep lab has a material safety data sheet. It's actually been updated where instead of MSDS, it's now called SDS, or safety data sheet. And it's basically a very detailed multi-page document that gives us a lot of information about any and all of the products that are being used, on what the materials are in the product, what safety precautions we might need to take, how to respond in certain situations, what to do if there's certain exposures, whether it was ingested, inhaled, left prolonged on the skin, all of that. So every single thing in the lab, we have an SDS on, which is why like your kits and stuff, they're for use here, and that's it. You can't bring your materials to the other labs or anything. Number one, it's an infection control issue. They can't attest to the safety and quality of it. And number two, if it's not on their approved materials, it can't be used in the lab. And it's even down to like the gauze, like something as benign as gauze, we have an SDS on. Oftentimes this stuff is kept online, like it's not necessarily a binder of it. But knowing where to find it is super important, especially if you do have a patient that has a reaction to it. So to give you an example, I put up some of the info from the SDS on 1020 paste. Basically, it's non-toxic and it's fairly skin sensitive, except for people that might be sensitive to paraben preservatives, like the certain chemicals that are found in cosmetics or topical lotions. So if you have somebody that kind of mentions, like, I'm really sensitive to da 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 da, then you might want to do a test area before you really start gooping this stuff on all over the patient's face and and scalp. If they accidentally ingest it, like say for instance your chin lead, it got pushed and they got it in their mouth or whatever, it's non-toxic. Have them drink water to relieve any possible discomfort. If they're starting to get any type of reaction to it, just wash the area thoroughly and then call the physician and for how to proceed if symptoms persist. This is like a scanned version. I took a picture of the Micro-Kill, those wipes that we use. Remember that, not the bleach ones, but remember the ones with the red. I think we ran out of them. But I wanted to show you guys this. So it's toxic, even via skin, dermal. Get it in your eye. It can cause damage and irritation. It can be harmful when it comes in contact with the skin. So if you're not feeling well after using these, call a poison center or doctor. So general advice is take precautions to ensure your own health and safety before attempting rescue and providing first aid. Avoid rubbing your eyes, immediately flush eyes with large amounts of water. So, I mean, these wipes, we are constantly using them, right? It's happened to me before where I'm wiping or cleaning, scrubbing the head wires. And how we clean them in the lab is we actually stopper up the sink and fill it up with like the chemical cleaner and the hot water. So you kind of hit it all at once and you just got to quick scrub them. But like, how many times have you guys been scrubbing with the toothbrush and have it like kind of splash you? Anybody? Just one of us, two of us? It'll happen. You're probably not scrubbing hard enough. But I've had it happen where it splashed me in the eye. What do? Flush your eyes, minimum of 15 minutes is recommended. So say for instance, you remember those wipes get really moist and like juicy towards the end when there's only a couple of them left. There's a lot of that cleaning fluid. So what happens if when you rip it out, you end up flinging it and it gets in your eyes or your patient's eyes? Remove contact lenses. If it comes in contact with your skin, immediately flush your skin with plenty of water while removing contaminated clothing. Don't reuse clothing or shoes until cleaned. If any irritation develops or persists, get medical attention. Don't put anything on it. So that's if it comes in contact with your skin. That's what I put this one in here because I'm guilty of it too, where I'll just quickly grab a wipe and like whatever, it's quick. It's how much harm is it going to be? But these wipes, they are pretty serious stuff. They've got some serious chemicals in them. So I just want to add this in to further reiterate the need to make sure that you're taking proper precautions before using these chemicals. If you inhale it, go out to fresh air. If it's ingested, call a doctor. Personal protective equipment, NA. So skin protection, wear gloves, eye protection, wear safety goggles while handling this product. You don't necessarily need any other protective equipment, but they recommend that you wear goggles and gloves when handling this. Here it's got some other like just properties of it. Acute toxicity, if it comes into eye contact, it can cause irritation. Skin contact can cause mild irritation if people with sensitive skin. So there's a lot of different, usually these sheets are like 4 to 7 pages long, depending on how kind of toxic the chemical is. Sidex, which is what we can use to clean the masks. We can reuse CPAP masks and tubing, but they have to be properly cleaned, and that's with alkaline glutaraldehyde or Sidex. It can cause allergic reactions if the masks aren't rinsed thoroughly. It can also use so the chemical itself, if you don't rinse it thoroughly, can cause issues, and it can cause skin issues as well, because not only, you got to think of where the masks are going. If you don't rinse them properly according to the instructions, it's not only going to cause skin irritation because of where it's resting on the skin, but then they're inhaling it. Like, this is a chemical that they are then inhaling. It's not good. Anything we use on the patient can cause allergic reactions. The electrode paste, as mild as it is, and any irritation or anything like that needs to be well documented in the patient's chart, because Can you imagine, like, if you go and have a test done and you had a reaction to something they used, they didn't document it, or the tech didn't bother to read the documentation, and then you have to go up to get a follow-up test done, and they do the same thing? Would you ever go back to them again? That's just negligent on their part. So document it well, and it just bodes to make sure you're reading the documentation as well. An allergic reaction can be life-threatening, and you know how we talked about hypoxia last week, how it has a snowball effect and it can happen pretty quickly and progress pretty quickly. Same thing with an allergic reaction. So as soon as you start to see it progress anything beyond a localized minor reaction, we need to respond, because you want to nip it in the bud before it goes anything further or more serious. Reactions can be localized, and it can be like a redness, bumpiness, whatever, or it can occur all over, whole body rash, hives, anything like that. But yeah, medical attention is always recommended for anything but the most minor and localized. So say, for instance, we're applying the electrode, patient complains of a little irritation. We take off the electrode and you can see it's like little, maybe a little red, whatever. It doesn't go beyond that. We can kind of just treat the spot, give them a cool compress, wipe off whatever was offending them that irritated their skin. And if it stays minor and localized, for the most part, we usually can go on. But if it starts to spread even the littlest bit, like beyond where you place the chemical, call it off and have them seek further medical attention, because like I said, it can progress. It can progress fairly quickly. Anaphylactic shock. Doesn't Doc talk about this shock? Okay. So I don't need to spend too much time on this. Involves the whole body. It's severe, and it's usually on subsequent exposures to a certain antigen. So your first exposure, generally it doesn't cause a major reaction, just once your body has developed those antibodies to it. So usually what happens is it's this massive release of histamine that happens during this allergic reaction, and that can cause a lot of just sequence of nasty side effects, where the airway can start closing up, and can be life-threatening if not treated immediately. So knowing some of the signs, symptoms, and how it can present itself, and this is why we avoid this at all costs, all these. If it's anything beyond minor and localized, medical attention. You're going to call 911, check the person's, do the ABCs, airway, breathing, circulation. You're going to be trained in CPR as of summer semester before you guys go out to clinicals, so you'll know how to respond in those situations. If possible, give the patient help to, so remember, this is very careful how we say this. We are not allowed to give medication, correct? It's not within our scope of practice. We cannot give a person medication. If the person has a history of anaphylaxis and has like the EpiPen with them, we are allowed to assist them in giving that to themselves. Do you understand the difference in wording here? Okay. Obviously, don't give them anything by mouth if their airway is closing up and they're having trouble breathing. As it progresses and if it starts progressing and you're waiting for emergency medical help, have them lie flat and raise up their feet a little bit to try to prevent shock. But any allergic or adverse reaction, make sure you document it very thoroughly. I not only want you to document what happened, what was the material, how you responded, and then the follow-up on that. Stuff was taken off, and then again, like I'll usually do a few follow-ups and kind of even end it in the morning, like as patient was leaving the building, this was their status, so that I can document from the start of the event to basically up until they left my care and how it was. So to give you an example, I had a patient, I think it was last summer. She was adamant that she was allergic to adhesives. And so I was like, okay, I don't need to use anything. I'll just use paste for everything, blah, blah, blah. But then she insisted that I use, and it wasn't allergic. It's hard to get a straight story from some of these people. It was actually how they're taken off. So I said, okay, I'm not taking anything off. I'm going to just unclip my electrodes and you're going to take everything off. but she was adamant that I take some of the stuff off of her. And so I started using as like the adhesive remover pads that we could use that we have. And then she had also brought mineral oil, but only brought like a tiny amount. And I could see that she was getting really red when I was trying with the stuff that she absolutely was insistent I take off. So I was like, I'm not comfortable. I'm not doing any more. You need to. And then, so I ended up, what I did was I documented a whole page. I mean, this woman was, if they didn't get a complaint about me from her, I would have been really surprised. But what ended up happening was just I documented up until the minute that she left. I documented my refusal. I documented her insistence. I documented how I responded and tried to utilize the methods that within my power to easily remove the things, what I recommended she do, right up until the minute that she left. So if necessary, use a second page. That's what I ended up doing is I just documented on a Word document, and it ended up being single spaced, 12 font, an entire page of what this woman, what paces she put me through, to put it nicely. And then I called my boss to give him a heads up, because there's no way your boss ever wants to find out like there was something that happened after the fact, you know. So if the patient did call to complain or anything like that, he was aware of the situation and he had my version of the events as well before it went in. I don't know if she ever did anything or did complain or anything, but as somebody on this end of things, I always appreciate a heads up if something happens. Like if you guys have issues in clinical, I always appreciate you giving me the heads up a little bit ahead of time before I get a call from like a preceptor or anything like that. It's important that we are knowledgeable of the disaster plans with any of like the weather related emergencies, knowing the emergency numbers. Obviously, like when you're in a hospital based lab, it gets a little bit easier because you know you have all the hospital numbers that you have to call, like the hospital version of security and all that. But when you're in a standalone lab, then you have to kind of utilize your outside resources like police, fire, like all of it. So you should be aware of where your exits are. This is for anything, and whether you're here at the sleep lab, anything like that. Know what to do in the event of a fire. Every single training that you'll ever go through for the hospitals, and you'll have to do all this stuff to clear yourself for clinical. It's going to ask you the basics of this type of stuff, which is what do we do in the event of fire? The acronym RACE. Every single hospital uses this. Rescue the patients, pull the alarm, call 911, if possible, contain the fire, close doors and windows. And if it's safe and you're able to do so, try to extinguish it with the fire extinguishers. We all must be trained and certified in CPR. You have to maintain a valid and updated license. So in the event of any cardiac or respiratory issue, call 911. If the lab has a defibrillator on hand, know how to use it. Do you know where our defibrillator is here on in the lab or on in this building? No. You guys have walked past it every single day. Yeah, it's right by the main suite doors for Suite B. It's right there. So it's important to pay attention to those little things, because the last thing you want to do is like once the panic sets in, if you have an event going on, like where am I going? Where is it? Ah! Like running around like a chicken with your head cut off. So if there's a life-threatening or potentially life-threatening situation that arises while during the sleep study, try to waken the person up and see how they're responsive, because it's a different scenario because we're watching them sleep. If you're seeing something on as you're running the study that could potentially be a serious thing, wake them up, see if it's real, see if it's not, make sure it's not artifacts, make sure that they're breathing, and try palpating their pulse. Document everything. So whenever possible, continue the video recording and the audio recording. And you're going to have to document it very thoroughly as well in your notes. Psychiatric emergencies, they do happen. Continue recording everything, especially the audio and the video. This is one of the reasons why that some labs have started to adopt the policy that as soon as the patient gets to their room, we are recording from the get-go before even the study starts, just so that their time is always documented while they're under our care. Whenever possible, go into their room, try to be calm them down. But if it doesn't help or it just keeps escalating, call 911, call for help. Tachycardia, bradycardia, emergency is when it's more than 120 or less than 40 for more than a minute. And it's not an association with because of respiratory issues that they're having, like apneic events or anything like that. Try to wake them up, see if their heart rate will normalize, make sure their airway is open, palpate their pulse. If after waking them up, their heart rate doesn't normalize, then you have to call the medical director or 911. But if it does normalize, oftentimes we can kind of continue on with the study, especially in the event of bradycardia, because we do sometimes just have people that their heart rate is low, and always check your policy procedure manual for if you had an event like this, even if you did wake them up and the heart rate were to normalize, does the medical director want to be notified, or because it normalized, you can just kind of keep going. That's one of those things that your policy procedure manual would have clear instructions on how to proceed. So in the event that you have a patient panicking, try to discover what's going on. Allow them to get up out of bed, walk around. Sometimes you do have patients that have panic attacks in the night, and so making them stay in bed isn't necessarily going to help. Well, do you need me to disconnect you? Do you want to walk around a little bit? What do you need to do? Give them some time to calm down. If they haven't after a period of time, then it might be time to call for further intervention. But usually, once you discover what the source of it is, if it's something within your power, we can generally calm the patient down enough to continue the study. Chest pain, continue recording, observe your EKG tracing, and call 911 if you notice asystole for more than 10 seconds, AFib, VFib, VTAC, or if the patient's having difficulty breathing. A lot of kind of the standard of a lot of these things is if the patient's symptomatic, if they're having difficulty, anything like that, err on the side of caution and just have them be seen by medical personnel before continuing the study. Nothing that we're doing is so dire that it has to be done immediately. Like, we cannot delay this test. If it means the patient's safety and health, just take care of them first. Patient is nauseous, let them go to the bathroom, obviously. If it doesn't go away, you when you have a patient that ends up being nauseous, it's one of those case-by-case scenarios of what's causing the nausea. I mean, I've certainly had patients that end up coming, when you come down with a stomach bug or food poisoning, you generally don't have a lot of warning when it's going to happen. So it's happened before where the patient's in there and all of a sudden, middle of the night, they get sick, and we usually discontinue the study and send them home because we're not going to get an accurate picture of what's going on. The important component of it is knowing when it's going to become an emergency scenario, like if they're lightheaded, diaphoretic, or they're heavily sweating, or if they're unsteady on their feet, call 911. It's not going to be this scenario of, do you want to go home or not? It's if they're showing those symptoms, they should probably be seen by medical personnel. I have had patients get nauseous in the night, maybe get a little sick, and then continue on with the study. It's not an automatic, I'm sending you home. I've had people that had really heavy postnasal drip and it made them really nauseous and they got rid of it and then they felt fine. You're here for the study, you're hooked up. I'm not gonna, if you know exactly, and it's a routine occurrence for you, I'm not gonna send you home. Seizure, name of the game here is keep the patient safe. When you're in the presence of somebody having a seizure, it can be very intimidating at the time, wondering, what do I do? How do I help them? Blah, blah, blah. I find that kind of keeping in the back of my head that knowing that there's nothing that I can do that's going to stop the seizure. It's going to end spontaneously. There's absolutely nothing in our power that's going to stop it. So our only role while a seizure is happening is to keep the patient safe. So if you're in their presence when it starts and they're standing or sitting up, try to guide them down to the floor gently. Continue the monitoring, obviously, with the sleep study whenever possible, but if it's going, it's going. If it's not, you're not going to run out of the room to go and turn it on. So if possible, clear the area where they are, kind of move any furniture or anything like that that the person can hurt themselves on. If possible, position them on their sides, because oftentimes, depending on the nature of their seizure and what's happening, they might not be breathing or swallowing or anything like that. So you want them to kind of roll to their side, that recovery position. So any fluid can leak out of their mouth, but you're not going to hold them down. You're not going to put too much pressure on their body or anything like that. You're not putting anything in their mouth. And the reason I add this is because it used to be where it was like standard practice where you used to put the tongue block in to like hold their tongue forward, and it was like this plastic piece that kept them from biting their tongue. Things have changed. It's no longer recommended. Do not put anything in the patient's mouth. It can cause injuries to the patient and it can cause injuries to you. Don't try to move them or hold them down, anything like that. You can injure them if possible, and it's easy to do so. Like I said, roll them to their side. If not, you're there just trying to keep them safe during it, that they're not going to hurt themselves on anything around them. Afterwards, check them for injuries, check their breathing. If they're having trouble breathing, call for emergency help. Check how their status of their clothing, everything like that is, because it happens and it's a lot is out of your control. So if anything got tightened or anything, loosen it from around their neck and their waist. Don't give them anything to eat or drink until they're fully awake and alert, and stay with them until they're familiar with their surroundings. So once you understand what your kind of role is and you have a calmer head, the important point is then to kind of observe the patient while it's happening, because a lot of information can be gained by observing the event itself and taking note of certain things like how their body moved, how long it lasted. So if possible, like take a look at the clock and kind of have a rough estimate of the time. How, if you were with the person, how they were acting right before the seizure, were they acting different or anything like that, and how they were after the seizure. How was the post-ictal period? Were they confused or did they wake right up? Anything like that, and whether or not they suffered any injuries from the seizure. Follow your policy procedure for how to handle this. Most likely you'll be calling the medical director, let them know it happened, and if necessary, call for emergency help. There are certain things that will always require you to call emergency help in the event of a seizure. A seizure itself does not mean an automatic, we have an emergency situation, call 911, especially if the patient's at the lab because of it. If they're getting tested because we know they have nocturnal seizures, oftentimes you kind of let them go. But you're going to call for help in the event of a seizure if it's lasting upwards of 5 minutes, because at that point it's at risk for status epilepticus, or like an unrelenting seizure. Then it can become life-threatening. If it's a new onset, like we have no idea, there was no history of the patient having a seizure, then yeah, it's an emergency situation. Somebody having a seizure out of the blue is not something that we're just gonna be like, oh, okay, that happened, let's keep going. We want them to be seen. If they suffered any injuries, if they're having difficulty breathing, or if there's a really prolonged post-ictal period where they're just really not coming out of it, like waking up after the seizure, then we should call for help. But like I said, it's not guaranteed always an emergency situation, but knowing what to do, how to respond, and what to watch for is absolutely part of our job. So these are things that you just have to commit to memory. Do you guys need a break or just keep going? This one tends to be kind of quick. Okay, electrical safety. So it's important to be aware of our diagnostic equipment, how the patient can become, how injuries can occur from the equipment that we're putting on them, how electrical injury can occur so we know how to try to prevent it. When we apply the wires to our patients, we are forming a complete electrical circuit between our patient and the equipment. So electrical injuries are an issue. It's something that you must be aware of. Luckily, though, with all of the way the building codes and things like that, it's not nearly as prevalent as it used to be. And it's not something that we have to be nearly as careful about, because the building codes, if you're working out of a building that's built to code and all the electrical outlets are grounded, there's a common ground for the building. For the most part, it can kind of do away with some of the issues, but in case that when there isn't, if you're working in an older building, things like that, that's where you have to be watchful for. So electricity can cause injuries by how it passes through the body. It'll remember electrical issue, it's from the electrical current, think back to electrical theory. It's the current that can cause issues as it travels through the body. So if it enters in one part of anywhere the electricity travels through the body, it can cause tissue damage. And so the severity of the situation really depends on where it traveled through. So for instance, if it traveled in one hand and then traveled out through that same hand or arm, basically the tissue damage is isolated to the hand or the arm. It's not too detrimental, but it's not necessarily a life-threatening situation. In the instance of where the electricity is traveling through the body and traveling through the heart, like say it entered in one hand and traveled out the opposite leg or whatever, it's traveling through the heart. So that means that the tissue damage can occur in the heart as well. The most serious situation is when you have patients that have electrical devices implanted, pacemakers, things like that, because oftentimes the electricity, the current will stop at that device and use that current's ground. So for instance, like in the event that a person has a pacemaker, that electricity travels right to their heart. And that's like the most dangerous scenario that we have. So you guys are your PowerPoints are going to be slightly different because I was actually revising this as you were taking the test. There's a couple slides that are a little slightly different. What I did was I pulled in, this is the copy of the slide from your electrical theory lecture, just to kind of remind you of the differences in voltage, current, and resistance. So some of the other factors in electrical injury is not the amount of electricity, and it's not the voltage that can cause the harm, it's the current. And current is directly proportional to voltage and inversely proportional to resistance. So remember, voltage is what is pushing current through. Resistance is what is preventing that from going through. Make sense? Rendering? Other factors in electrical injury is whether the skin is dry or wet, whether it's broken or intact. So dry skin has a fairly large resistance versus skin that is wet, and skin that's broken, it reduces the resistance as well. Electrically susceptible patients, so patients that have any type of indwelling electrical devices, infants, things like that. When we have these high-risk patients, even the smallest current that might barely cause like a shock to your finger or a zap to your finger can be potentially lethal for these patients. So those are the ones that we really have to be very, very careful with. So the effects of electricity on the body, it doesn't take much to go from like a slight tingling to like, oh, I need to let this go, to causing that tetany, which is the muscle spasms and kind of involuntary contractions. It's not too far of a path here to go from one to the other. And then even in like the instance of extreme shocks, like somebody that got hit by lightning, it can cause somebody to split in two. It's been documented to have like spinal cord resection, or like the spinal cord split in two because of this like extreme shock that occurred. So this is all like macro shock, the effects of electricity on the body, which is like the current coming through. This doesn't describe the instance of micro shock, or like just the tiniest little current that can really cause these kind of serious effects for these patients that have the indwelling catheters, things like that. So kind of what happens during electrical shock, or like when somebody gets zapped with electricity. Acutely, it can cause, their heart to stop, or their heart to kind of miss some beats or whatever. It can cause, because again, it can cause that muscle tetany. So that affects all your bodies, including your diaphragm, your heart muscles, like all of that. It's more the latent issues that is where it can be more detrimental, because where the electricity hits on the body, it can cause necrosis or tissue death. And so wherever it happened, it's usually that necrosis that kind of causes the body to start to shut down, like depending on how severe it is and how progressive it is, that can really cause these like really nasty issues that could be ultimately what's fatal for the patient. So macro shock is when you get the bigger shock. It, like I said, that previous slide with all the how much shock, how you're going to feel it, but where you receive a shock from one part of your body and the current passes through your body, and another part of the body is like touching the ground or whatever. So the electricity is traveling through you. Micro shock is shock that's with a very low current, and it could be like just very, very minimal, but with somebody that has an indwelling catheter, indwelling pacemaker, anything like that, it can be an incredibly dangerous situation. There's a difference. So the other thing to take into account in the sleep lab specifically is sweat will reduce the body's natural defenses against electrical injuries, so shock, anything like that. And our patients are very sweaty. They are a sweaty bunch. And then on top of that, what we're doing to the skin, we unintact it. So we're taking that prep and we're scrubbing their skin and kind of abrading their skin. So whereas, remember, dry, intact skin is more resistant to electrical injury, we're doing the exact opposite of that. We're using an electrolyte paste that has sand in it, and we are unintacting their skin to abrade and kind of, not entirely break their skin. It's not like open, but microscopically, yeah, we're abrading their skin to reduce the resistance. And so think too, back to that electrical theory, resistance is one thing that can help protect a person from shock, and we're reducing that even more. So we're removing the natural protective nature of the skin, and kind of if there were to be a current or something to happen, we're making our patients more electrically susceptible to the negative impact of that. So it's important that all the electrical equipment that we utilize is properly grounded. Everything is installed up to code. I know this is things where it's like, well, how am I supposed to know that? But just working at a reputable place, at a reputable lab, in the building, whatever, I don't want to say we should assume, but for the most part, most things are done up to code. Yearly, all medical equipment needs to be inspected by Biomed in order to check it for its integrity, its safety, all of that. What is our responsibility is to check all the equipment that we're using on a daily basis. So as you're cleaning the equipment, taking anything that's frayed, broken, taking it out of commission, and while you're applying it. Sometimes you might not notice it when you're cleaning it when you're done, but when you're applying, you might notice, oh, this is really frayed. Take it out of commission. Do not use it on the patient. That's your responsibility. So when we talk about ground in relation to electrical safety, it's basically the safe path that if there were to be a voltage or a current to come through, that it can safely exit without causing harm to the system or to a person or anything like that. That's one of the reasons why that the electrode, the ground electrode on the forehead, it's not referring to an electrical ground. Do you guys know that? I don't know why in sleep it's a reference, but the one on the forehead, it's called the ground. It's not the electrical ground, which is one of the reasons why I don't say it ground to the patient, because most people think in terms of electrical safety. I've said that before, and then I've had the patient look at me like, oh my God, so if a shock is going to occur, if there's like going to be a surge on the building, this is where the surge, right in the middle of my forehead, where it's going to exit. Are you kidding me? So I don't even say ground. It's honestly like our reference, and I don't know why in sleep we call it the ground. It's a reference. So I just use that term because most people come back to the term ground in terms of electrical safety. 3-prong outlet, 3-prong power cord. We have to and always use the correct equipment or the correct power cords. Like you're never using the adapter to make the 3-prong cord fit into a 2-prong adapter. You know what I'm saying? Those little like adapters that you can get. Avoid extension cords whenever possible. Be gentle with the cords, inspect them regularly. Anything that's broken or frayed, take it out of commission, take it out of use, and call. You know, I'm not training you guys to be biomed engineers. I'm not asking you to be able to fix your equipment. I'm asking you to be able to just recognize like that's not appropriate. You know, there's a really long extension cord that's coiled and kind of frayed. I'm going to not use this and not, you know, just kind of go along with it because that's what the lab does. So we're not using extension cords. If absolutely possible, it has to be a medium or heavy duty, and it has to be polarized, which means that the one prong is wider than the other, and it's got that 3rd prong for the ground. You're never using the adapters to connect, you know, like one thing to the next that doesn't properly fit. Uncoil it as well because it can be a fire hazard. You're not overloading outlets either. It's not, what is that movie? Christmas Vacation, right? With Chevy Chase that I'm thinking of, like for the overloaded outlets of all the Christmas stuff. It's not going to do that. If the equipment isn't plugged in correctly, you know, anything that we keep adding to the system, the adapters, extension cords, overloading the outlets, it's all increasing the patient's risk for shock if something were to occur. And while we can have as many safety measures in place as possible, using things that are inappropriate that shouldn't be used are all going to increase the patient's risk. And it's just kind of like asking for issues. So one of the things we have to be mindful of in the lab is what's known as leakage current. And it's essentially like, you know, a battery kind of slowly drains itself, like your cell phone. As long as it's on, you might not be using anything, the battery is going to slowly drain and eventually die. Kind of it's the same thing. It's a gradual loss of current from a charged capacitor or charged kind of battery. And so proper grounding, not using electrical extension cords, all can help reduce the amount of leakage current that happens in the lab. And where leakage current can become dangerous, because it's normal to have some leakage current, but where it can become dangerous is where that leakage current is going. It's not necessarily just like going into the room. It could be just kind of going into the electrical system that we're applying to the patient. So making sure that the equipment's properly grounded so that if there is a leakage current, it's going out in a safe way. So some leakage is normal. 100 UA is the maximum acceptable limit. So if we have biomed come in and test all the equipment for leakage current, and they say, hey, your bed 2 amplifier has a leakage current of 120, what are we doing? Exactly. When I ask this question, oftentimes people will try to start telling me how to fix it, and I'm like, no, we're not engineers. That's not our job. We just don't use it. And we call whoever needs to be called to come and fix it, but you don't use it. Ground loop is when there is more than one electrical path or electrical ground in a system. And that can happen if we're interconnecting pieces of equipment on the patient, like if you have more than one amplifier hooked up, the patient's coming in with an ancillary equipment on, say the patient's having their sleep study done and they're wearing like a Holter monitor to long-term monitor their EKG, anything like that. Essentially where the danger lies is if there was a current, if there was a shock to happen, sometimes the current doesn't know which path to take to exit and it'll loop between the 2 grounds instead of just taking one of them to exit. Does that make sense? what a ground loop is? Do you want me to say it again? Okay, you guys are like not with it today. Here's another kind of explanation of it. So if you have two pieces of equipment that has separate grounds, basically if maybe the ground wire fails on one, then what can happen, so say you have two pieces of equipment, the ground wire fails, leakage current from the one where the ground failed might travel back through the body to get to the ground on the other one. The basic premise here is to make sure that there is a single common ground for any and all equipment applied to the patient. That way we don't have this issue of, well, if one ground fails, then you're having current travel through the body to get to the next one, or if you have two grounds and you're having the current kind of loop between the two grounds instead of just taking the path of least resistance to exit appropriately. It's unlikely that this will happen in the way the equipment is set up and the way that the buildings are built to code and all of that. And additionally, what we do, and another safety measure that's done, is that our equipment is isolated, electrically isolated, so the patient is isolated. But it's still a potential issue that we have to be aware of. And the more the leakage current, the more the risk there is of ground loops. So electrical isolation is basically, it's isolating the patient. So that way, if there was like a storm, lightning were to hit the building and you have a surge, you know how you can have that surge through all the outlets and it can fry your electrical devices. That surge is not going to travel through the equipment, through the amplifier, through the wires attached to the patient and hit the patient. Make sense? They're isolated. So there are safety measures in place that isolate the patient, that stop that electrical surge from ever actually coming all the way to reaching the patient. I feel like I said all that. So the last thing electrically that we have to be careful about is chemical burns from a battery. So remember, batteries or usually batteries, but DC, direct current. It's a very basic form of electricity where it only goes in one direction, negative to positive. There's the set end, like a battery. There's always a set end, a positive and a negative. And so what happens when you have like a DC current style piece of equipment placed on the patient, you have the positive and you have the negative end, and each is capable of causing burns in a relatively short amount of time, because ultimately our skin and our tissue is filled with electrolytes, positively, negatively charged electrolytes. And as these positive and negative charges are placed on the skin, the electrolytes are going to start getting attracted to the battery. Negative electrolytes go towards the positive electrolytes start going towards the negative. The longer these are on here and the more the electrolyte buildup, the more serious and severe the chemical burn can be. And that's essentially what happens, is this kind of pooling of your body's electrolytes can cause like a burn or like a chemical burn in the skin. So it's something that you always have to be mindful of whenever you're using anything that's battery operated on a patient. Like here's an example of where a patient wore a sat probe on her left thumb and she had an EKG ground on her right leg during surgery. She complained of prickling pain on her thumb right before surgery, but they told her it was fine, put her to sleep, did the surgery. And then she ended up with lesions on her thumb and on her leg where those things were applied because of the passive current between those two things. One was positive and one was negative. And then what ended up happening, the lesion was a dark gray, dry, necrotic lesion with small perforation near the catheter. And so essentially kind of the takeaway from that is always listen to your patient. If they ever complain of pain, anything like that, discomfort with anything that we're using, listen to them, because it could be that something happened where there's a leakage current going on that is causing kind of the imbalance where it can cause that chemical burn. of like the positive negative diode. And especially if it's something that's battery operated and we have it attached to the patient, and we apply 2 different types. Remember, we use the DC amplifier for like our respiratory equipment, our SAT probe, things like that. The AC amplifier is what we're applying and using for like our EEG, our muscle stuff, our eyes, all of that. So understanding kind of the electrical background of the things that we're putting it on. So how can we prevent injuries? Just being aware of what the source of the danger is. So if there's any question onto the integrity of like the wall outlet that we're using, don't use it until it's been inspected. Test the integrity of your equipment. Actually take a peek at the wires, make sure that they're not coiled or broken or frayed or anything like that. Don't ever use a cheater, like where you're connecting, you know, those little prong adapters where you're connecting a 3-prong outlet to a 2-prong outlet, or 3-prong plug to a 2-prong outlet. Speak up. If you see something, say something, because it's your responsibility. If you then saw it, didn't do anything about it, and just, you know, like, well, and how many times like, everybody else is doing it that way, must not be that bad, and just continue to do it, well, you're liable. You are, for continuing to use it despite knowing better. If the 2-prong outlets, if only 2-prong outlets are available, then you can't run the test safely. You cancel it. Nothing is more important than keeping our patients safe. And if we can't run the test safely, we're not doing it. Never use equipment where the ground prong is loose. Make sure that the instruments are routinely and regularly tested to meet the leakage current limits. Never using extension cords whenever possible, anything like that. Okay, last little bit, ethical legal issues. So our patients have the right to refuse anything and everything that we're doing. They also legally we must obtain consent for every procedure that we do with the patient as well. They have the ability, it's like that patient bill of rights. In order for them to get information, they're allowed to have this open kind of flow of information on what we're doing, what their diagnosis is, what the treatment is, any and all aspects of their care and their treatment team. Any risks or discomfort for everything that we're doing, the patient should be well informed of, and hopefully that's all been done prior to them coming. But that's also one of the reasons why I've been pushing you guys on your communication, making sure the patient knows what's coming, because part of consent is just getting in like verbal consent. You know, I'm gonna take your vitals. Do you mind if I grab your wrist? Patient says yes, you just got consent, right? Things like that, making sure they're aware what you're doing and how you're putting it on. Like, I'm going to use a little bit of prep now to scrub your skin. It's going to be a little cold, but it's not going to hurt too much. It's not going to hurt. You know, you're getting consent. If they say no, then you stop. Everything that we do requires consent. The level of risk on what's being done is whether the consent is verbal or written. For the most part, a sleep study needs written consent. So part of the process of what we're doing with our patients is we might be having them sign a consent form and when they arrive to the lab. A lot of labs have that, where that's like the first thing. We have to get consent for the test before we're able to move forward. Part of that usually involves like the video and audio recording as well, so the patients are aware, it's in writing, they've been given well aware that, you know, this is all happening. Making sure that when you give them the consent form, they're able to read it. Like, that's part of the big thing too that they're pushing with a lot of these medical documentation things that we give the patients, that it's not in so technical or legal jargon that the patient has no way of understanding what they're getting. It has to be written in a way that they're going to understand, because then whose fault is it that they consented to something that they truly didn't want, but they didn't really understand what they were reading? Make sense? So everything that we do is voluntary. A patient has the right to refuse any or all of it or parts of it. So because of all the things that we're applying to the patient, it's considered a high-risk procedure. It's not high risk in that it's life-threatening, but it's high risk in all that we're doing and all the different things that we're putting on them. And it does require written consent. But if we were to do, like, you know, take a quick set of vitals when they come into the office, that is verbal consent would be fine for that. Like, you mind if I do this? Sure. Okay, move on. You don't need to get them to sign something in order to take a quick set of vitals. In the instance where the patient is a minor or incompetent, you have to have somebody from that is responsible for the patient sign the consent forms. Even like a teenager, you know, it's sometimes I forget, like, oh wait, you're not 18 yet, mom, you need, or mom or dad, they need to sign the consent form. Even if they are a minor or an incompetent person and that they're not able to sign their own consent forms, they have the right to refuse. You know, so you have to listen to them. We do not have the right to authorize or dispense medications or even make recommendations. I've had plenty of people ask me, well, what do you think of melatonin? What do you think of this? And even if it's a supplement, I'm not saying anything. Like, you need to talk to your doc. I recommend you ask your doctor about that. Even like something as simple as like headache medicine, like if the patient comes in, they have a headache, even if you have it, they seem friendly, don't give it to them, because if they were to have a reaction or anything like that, it comes back on you. Patients are allowed to self-administer. They can give their own medications. Part of patient safety is protecting yourself as well. I've said this before, but I'm going to say it again. We aren't trained to deal with violent or difficult patients. Like, I'm not training you on, what are those techniques, those hold techniques or whatever, the restraint techniques. We don't do it. If it comes down to that, you take yourself out of the situation. And that even includes just verbal things. So people making obscene remarks, things like that. You have the right to end the study. Usually I'll give them a verbal warning, like, listen, that's not appropriate. This is a medical procedure. If you're going to keep behaving like that, I'm going to have to end your study. And usually that's enough to make them kind of act right. But if they don't, or if you're just really that uncomfortable with the situation, you can discontinue the study, call security, call, if you're in a private lab, call 911 if necessary, to come and take care of the patient, to get them out of there. You can switch patients. So for instance, female, if you're uncomfortable with a male patient, if there's a male tech, hey, do you mind taking over this patient? Document it well, because so that way the next time they do the scheduling, they make sure it's not just female techs on when they schedule this person to come back, and vice versa. I've had my male coworkers ask me to take over a patient that they were uncomfortable with because the female thought it was appropriate to wear a negligee for a sleep study, and he did not want to be in the room with her, which I don't blame. You know, absolutely, I understand that. So just kind of being open and asking for help or switching whenever you're uncomfortable or anything like that. Document, it's huge. Document everything. It not only protects you, but it protects the patient, it protects the sleep lab in case if there is litigation, like if the patient were to like sue the lab for something, and it happens more often than most medical places like to admit, because they oftentimes will just settle out of court to avoid the long trial. So it happens fairly frequently. So understanding your role in that, which is your documentation and responding appropriately, all of that. Because it can be used and will be used in litigation. The policy procedure manual is your friend. It will tell you how to proceed in even the most mundane situations, what to do, who to call, how you should respond. You can be held liable for failure to follow your policy and procedure manual. So a huge part of patient safety isn't just knowing where the manual is, kind of being a little familiar with the layout. Like, I'm not going to have you guys memorize the policy procedure manual for every place you go, because every lab has their own. But you are responsible for knowing where to look when you do have questions and knowing where it is. Okay. So that's it for this lecture. What I'm going to do is I'm going to hand out the lab for this, because it has a lot, kind of just asking you a lot of like just questions about review from this lecture to help you study and prepare, because that's what we're covering in lab. We're going to do like fall, we're going to I'll show you guys how to read the SDS, what to do in case of an allergic reaction, the electrical safety, kind of understanding how to respond to certain situations for like disaster planning, and then seizure, like how to respond, like everything from this slide. So I've been finding that you guys I can feel you're all sliding, And so when I'm asking you questions and trying to review what we cover in lecture, it tends to be like a one-way conversation. So I'm giving this to you now, and you can start working on these questions now. So you review the lecture a little bit and kind of be a little more familiar with what we just talked about when you come to lab on Wednesday or Thursday this week.